right, so my name is Eric Olivas. I'm the chair of the Northeast Heights Community Policing Council. Thank you guys all for coming out tonight and joining us for our March meeting. It's a pleasure to have you guys here. We realize this is your time just as much as it's our time. So every meeting we just like to start out and thank everybody for that and remind everybody of that. We're all here, we're all sharing this space, we're all sharing this time. And we all are here because we care about our city, we care about our police department, and we want to have the best police department we possibly can for our community. So we're all here on that note. If you're not here for that, then you might be in the wrong meeting. I don't say that in a rude way. Just make sure you are in the right meeting. And we just want to work constructively, collaboratively here. So just please respect each other, respect the board. Again, we're all volunteers here. We're all giving our time tonight, so just respect that. Be polite, be respectful. We do ask that audience members refrain from any kind of crosstalk. If somebody is speaking, please don't speak to them while they're speaking. Communicate otherwise. If you guys want to speak in the hall or something like that, that's more than acceptable. If you have a question or concern, and usually most of our speakers and most of the board hangs out here for a while after the meeting. If you have any questions or comments, concerns, just stick around and we certainly have a little time at the end to address that. And then as far as our speaking time goes, during any section of the meeting, you feel more than welcome to raise your hand if you have a question or comment. Just be aware that we do ask you keep your comments brief, not repetitive. We try to limit comments to about 2 minutes, and if we have time at the end of a time period, we will let you ask another comment if there aren't other folks in the audience looking to speak. So just keep that in mind, and I think we'll have a good meeting. So tonight, we do have some business that we've got to take care of, but I know that everybody's here to really learn about our behavioral health system. I'm really excited that we have some speakers here tonight. We've got Nevin Marquez, the Director of Behavioral Health at HopeWorks, New Mexico. We've got Dr. Carla Eide and Detective Briones. Dr. Eide works out at the Metropolitan Detention Center, and then Detective Briones works with the CIT unit. So I think it'll hopefully give us a nice picture of sort of the cycle of behavioral health needs and the cycle of behavioral health problems in our community, what's happening with them right now, maybe what we need to improve, and where we come in as a community and as a council for how we might be able to make some changes. So look forward to hearing from them and also hearing from you all. If you have any ideas or input on how to change that, better that system, that's what we're here for. There are a couple numbers. The website for the Northeast Area Command is on the board up there along with the phone number. If you want to contact them for any reason. Periodic watch, if you have any safety concerns, traffic issues in your area, that's a great first place to start. We also have Commander Byrd and Sergeant Sims here, who are both great resources here in our area command, so you can certainly ask any kind of questions you have, and they will more than likely be able to address them in the very near future. So, with that being said, we also have a note on the agenda. I handed out some note cards to some of you. If you didn't get one, there is some note cards in front of our other resources. Point of those is we want to get feedback from you. This is your community policing council, so we do want to get feedback on what we're doing well, what we're not doing so well, and what you'd like to see us do. So guest speakers, topics, recommendations, anything like that. It's just useful for us to get that feedback periodically, and we will try to do that more often. So there's pens up there also if you don't have a writing utensil, you can access those. And you don't need to put your name on it or anything like that. It's totally anonymous. You can leave them at the front when you leave, or you can leave them up here, whatever works for you. All right, so with that being said, we have some business to take care of here. We have an agenda that should be up front. You all should have seen that, and our February meeting minutes. These all went out with our email list. One other thing I should say, when you sign in at the front, if you put down your email, you automatically go on our email list. We don't share that with anyone. That's for internal uses only. But that is how we communicate these things with you, and that's how we give the public access to all of these things that we produce. So things like agendas and minutes, but also recommendations and other documents like that that you might want to give us input on. So that's a good way to collect that. And there will be a slight change to our agenda tonight. These were printed before I got notice of this, but the report from the Neighborhood Watch and Safety Advocates Committee will be delayed. Janet Butts, the chair of that committee, is not able to make it tonight, so she's going to speak to us in April when she'll hopefully be here. So we won't have that item, but I was hoping, I don't want to put our new members on the spot here, but we do usually try to get a very brief report on ride-alongs. So I know you guys both went on ride-alongs recently. So if you're prepared, it might be nice just to hear some highlights of that or what you thought of that. Give everybody an idea of what you saw and that sort of thing. So that's kind of where we'll plug that in if we have time, if that's all right with everything. So with that being said, do we have a motion to
move the agenda as modified, be approved, and the minutes be approved?
Second.
We have a second. All in favor say aye. Aye. None opposed. Motion passes, and we will adopt the agenda and the February minutes. So we also have some new business to consider here. We have a very brief change in the annual report, a very minor change. We just added our recommendations from last year. We passed this last month with the stipulation that we would be adding in the recommendations we passed last year. There were 4 of those: bicycle patrols, neighborhood watch, the CPA, the Citizen Police Academy, and the community outreach position. So we're just simply adding that text to this document, and then Dorothy Woodward here also had a change to a date, I think, that you noticed in there that was wrong. So pretty minor changes, but we will go ahead and see if we have a motion to revise that.
Move the approval of the annual report as modified.
All in favor say aye.
Aye.
Opposed? The motion is passed to adopt the annual report. That's available, or will be available online if you're interested in seeing any of our business or highlights of what we did. It's a great summary of everything for the year. So the next item we have here is resubmission of recommendations. So part of our changes that we made last time to our guidelines implemented a system of committees. So we're going to have 4 committees now. We have a Rules and Operations Committee, a Policy Committee, Recommendations Committee, and a Community Outreach Committee. The idea is that you guys all know these meetings are pretty rushed. We don't always have time to really delve into things. So the hope is that these committees will be formed. We plan to make them public so that people can come and participate if they like. But the point of those committees is for us to be able to function as a board and produce high-quality work, recommendations, changes to our guidelines, all those kinds of things, so that it's done in a more public and transparent way where the community can participate, but also so that we can just get it done in a timely manner where it's equitable work among all of us. So because of that, this resubmission of recommendations is actually going to be tabled, I believe, and moved into committee. Correct? So that's going to be removed from our agenda tonight with that, and that will be brought up at the first meeting of the recommendations and committee. All right. And then we also have on here a report on outreach from Anya Romero.
Sure. Good evening, everyone. It's so weird to be here and the sun is still out, but I'm not complaining. But very happy to report that those of you who have been attending our meetings, there's definitely a goal to get some younger faces onto the up here at the front, and we actually have our first applicant, and we thank Commander Byrd for bringing him to us. I reached out to him. His name is Taisir Ali, and he's a senior at La Cueva High School and is also their student body president. And so he and I spoke last week, and we had an amazing conversation about him joining us here at the Policing Council. And I really, the board, we've talked about this, and we've brought this up during our meetings, but if we really want to change our communities, we have to bring young people to the table. And we have to make sure that we have their input as well as to what's going on in their, in school amongst their peers. And he definitely is interested in joining. He was supposed to come tonight to kind of watch the happenings of what we do here, but he was unable to make it tonight, but he will be submitting his application. And in the process of what his role will be, we've discussed it amongst the board, but he would definitely be a voting member. It makes no sense to have someone, and young people, they have valuable things to contribute. So we believe that the youth member should be a voting member, which means that he would also have to partake in a ride-along and all the requirements that come with it. I spoke with him, and he definitely is in full agreement and very excited about doing the ride-along. And we also discussed the time frame. So many of us have 2-year terms. So the youth member would only serve a 1-year term. They have lives to lead, and if they're graduating from high school and heading off to college, we want to make sure that we're accommodating that. So he should be submitting his application soon, but I'm just very excited. And if any of you know of any other young people who we could bring on, please let us know. We're really looking forward to Taisir taking the lead and helping us to get more young people, and I see young people in the front. So very excited to report on that, and can't wait to welcome him.
I'm fortunate, we call him T. He coaches my son's football team. He also played football at La Cueva, and he would go from his high school practice, which is demanding, and then come and volunteer in the community by coaching my youngest son's football team. He's a great young man. He has a bright future, sharp individual. So I think his feedback will be good. And I'm looking forward to it. This year's a good person.
So with that, we do have a slight change that we have to make to our guidelines because we're currently capped at 9 members. But the internal discussions that we had were that this is something that's very important to add that perspective, to add that diversity to our board. So in the email that was sent out here, it didn't make it on the agenda tonight, but in the emails that was sent out, there was a copy of those slightly altered guidelines. Basically, all it does is allow us to add additional seats for other members that meet criteria that align with some of the underserved or underrepresented populations in our community. So I would ask that we go ahead and move those amendments to the guidelines. If anyone has any objections to that because it wasn't on the agenda, we could certainly revisit that in April, but it was included in the email that went out. So if there is any objections to that, we can accommodate.
Move to amend.
Second.
We have a second. All in favor say aye.
Aye.
All opposed? So we'll go ahead and adopt the amendments to the guidelines, which will allow Taisir to apply and be considered by us. He'll still go through all of the normal application, interview, ride along, so there's really no special treatment there or anything like that. We expect that he'd participate just like any other member of the board, and we appreciate that. So looking forward to that. Any questions from the audience or comments from the audience so far? Just to make sure everybody's up to speed. Good. So I just want to take a minute and recognize Commander Byrd now. I think we talked about this last time, but he is officially our area commander here for the Northeast Heights. He's been performing that role for quite some time, but I think we should all be in very good hands with him, and I'll turn it over to him.
Thanks, Eric. I appreciate it. So I know I'm on the agenda to talk about crime prevention and crime stats, but I wanted to talk about some of the initiatives that we've implemented and have already taken place. One of my primary objectives is to get uniformed officers into the neighborhoods. So I've instructed the officers through the chain of command, through their lieutenants and sergeants, to make sure that they have at least 2 hours during their shift, allowing a couple of officers to do proactive, high visibility patrol, working from inside the neighborhoods out to the main arteries, so that the individuals and our citizens in the neighborhoods see that police presence. In doing so, I asked each sergeant to conduct a operational plan to their purview, whatever they wanted to do. And one of the plans was from our Team 3 Sergeant, Sergeant Robert Stockton. And he decided to target some of the traffic enforcement in and around our elementary schools, because we get an abundance of complaints from concerned parents, concerned teachers about people driving and individuals being hurt. He went into 3 in sector, I want to say sector 42, and wrote 65 speeding citations.
So what is Sector 42? That has no meaning.
Sector 42, so it's our beats, the beats in the central portion of our area command. And that's how we identify, we have 3 sectors in our area command, Sector 41, Sector 42, and Sector 43. We are currently in Sector 43. And so when you go south, it goes into Sector 42. Does that make sense?
Except, would you say like what the major streets are?
Major streets are Sector 42. Danny might be able to help me a little bit better because it changes a little bit. Montgomery, Comanche, Candelaria, from Wyoming
down to
San Mateo.
Okay.
And he went out, and we're talking about maybe an hour in the morning, an hour in the afternoon on his days. He wrote 65 stations or citations, and more importantly to me, he made 150 community contacts. So he got his officers outside of the patrol car, going out and talking to people and educating them on the importance of traffic safety, especially with our youngest population, our youngest student population, and did a really, really good job. And it is the epitome of what I want from our teams with their operational plan. Proactive, educational, preventative, enforcement type tactical plans, and engaging our community. And that completely was based off of concerns from citizens, concerns from educators, and getting that proactive police work. So it's really catching on. I was able to meet with my supervisory lieutenants and sergeants last week and conveyed how important that is to you guys, members of the Northeast community. And what I'm asking you guys to do is pass along that information to me, to my lieutenants, to my sergeants, to the officers, so that we can get those activities going on a regular basis. I'm hoping that we can get every sergeant on board engaging the community in those type of initiatives. I'm really excited for one. Everybody knows with the shooting down in Florida, we have another sergeant that is going to work with all the high schools, getting schematics for all the high schools, getting their internal operational plans for any type of violence that occurs on school grounds. And it was kind of a breath of fresh air, because all the principals, gave me a call and said, hey, we've never had this type of interaction with the police officers, and now we've even scheduled a coffee with a cop at La Cueva High School. So we're getting inside the high schools, and we're going to be able to engage with the help of Tajir, getting into the high schools and talking to our teenage population, which is important. So those are the type of initiatives that are going on. You'll be happy to know that we have 4 bike officers. We got some funding for some bikes. We have 2 current officers that are already trained, that are going to be TDY'd to the PAC unit. And then we have our 2 TDY officers in the back that will be going through training and getting bike certified. So we'll have those guys out on bikes, hopefully by the end of March, beginning of April. So those are some of the proactive, preventative measures that we're taking in the Northeast Area Command. We're still really concerned about property crimes. It seems like when the one nice thing about our problem is that when we see the problem through our crime analysis, we're putting resources out into that area, and we're moving it. So it tells us that our crime analysis is working. The problem is we're just dispersing it into other locations. So we need to become a little bit more strategic in anticipating where our bad guys are gonna be moving. So we're doing better. Property crime in the Northeast is down slightly. Auto thefts are still a major concern. But with the help of our tactical unit, getting into their blue uniforms and doing high visibility patrol and going out and taking calls for service, we're tackling some of those issues in the area command. So some pretty exciting things, at least in my world. It's good to have control of that type of stuff and be able to direct those type of activities and really get back to the foundation of community-based policing. Getting into the neighborhoods, listening to the community, listening to their needs, so that we can guide our resources based off of those needs and those requests. So it's really a pretty exciting time. I mean, and I have to commend our administration in providing us that type of support and that type of leeway to let some of the lower priority calls wait so that we can get officers into the neighborhoods. So that's a great thing, and and it comes from top-down leadership from from Chief Geyer. Forgive me, he used to be my commander in the Southeast. So. But I'll open it to the floor for any questions or concerns or anything that you guys are experiencing. Yes, sir.
The big problem is these sober homes. They put one near Montgomery, Wyoming, in between 3 liquor stores. And the probation people and the judges, they don't give these guys any kind of charm school training. They come in, they act like they just got out of the joint. They're in the backyard smoking 10 of them at a time, cigarettes, dropping F-bombs. You name it, they do it. I got a whole list here, but just think of your worst neighbor, and that's these people. And they've come and they arrested 2 of them at least. And it's just mind-boggling that the judges and whoever the courts are putting these people in there. I'm surrounded by 71-year-old neighbors and little kids, and these guys are acting just crazy. And had 5 car break-ins in the last 6 months. But someone needs to come by and do spot monitoring or something. I mean, I've waved over to the U.S. Marshals and they just wave goodbye and speed off.
Would you explain what kind of location you're talking about, or facility? I didn't catch that.
I've never heard of sober home.
Okay, well, it's a halfway house, and then I just heard of another term this morning, dismiss home. It's where convicts come out of jail. I guess they have to be sober for 2 months, 4 months. But I've seen them, U.S. Marshals come in, 7 of them, bulletproof vests, and arrest 1 guy. And here I'm supposed to live next door to 10 of them.
I'll look into it. I'll get some more information and get some resources out there.
Yeah, I've asked for about 3 drive-bys, my neighbors have, but it's just nothing. The secondhand smoke's enough to kill me. We're going to set up some fans, and I'm sure you guys are going to come out in the middle of an argument. I've called the city council. No city councilor wants to do anything about it. They say it's the Disabilities Act of 1988, and I don't see how a 250-pound 30-year-old is disabled. It's a big crock.
Sir, I'll look into it, and perhaps after the meeting I can get your contact information.
Okay.
And see what type of resources we can have to at least help alleviate some of your problems. What's that?
Go ahead.
Commander Burke, obviously I think it's great with the community contacts now that you're going one-on-one outside a car. And the bike officers, those 150 contacts, can we furnish, as we find a way to furnish and buy more business cards? Is that an opportunity that we can hand them the Community Police Council cards, and then they can build upon that? Maybe we can continue to create some interest as far as them coming to a meeting in their local 6. But that contact's so great, and we kind of leave them. By the way, if you want to learn more, here's a card to find out when the next meeting is in your neighborhood or sector, or however it breaks down.
Absolutely. Be really good. I mean, just not there, but also when we go out to our neighborhood association and homeowners association and block captain meeting, giving that information. Absolutely.
Okay.
Yes, sir.
Could you re-explain something you at the beginning of your talk, you mentioned something about telling your sergeants to have somebody starting from neighborhoods and working their way out. Did you mean per shift, per officer?
Per shift, per day.
Okay.
So just a couple of hours, and sometimes it's really difficult. Sometimes we're so busy going from call to call to call. I still want those sergeants to take 1, 2, 3 officers and go into a neighborhood and drive around the neighborhood, get out of their cars, talk to people. And when I say go into the neighborhoods and work their way out, I don't want them to focus on our main drags. We want them inside the neighborhoods, street by street neighborhood policing. And that's really the focus of the idea,
Okay.
in addressing some of those issues.
Anyone else?
Any other questions I can answer? Yes, sir.
Hello, I'm Dole. I have a question related to how are we utilizing information from criminal, if we catch a drug addict or, anyone who commit crime, and they can be very good source of the information, how they plan, how they become criminal too, from what kind of family background and where they live, what kind of network they utilize, what kind of resources they use. It's a little bit bigger thing to explore, and sometimes we put them in prison, and maybe not exploring enough from them. And I was thinking, if we can provide some safe space for them to provide, good information, how they are doing, what they are doing, and explore a little bit, milk them, the information, and that may be helpful, I'm originally from Nepal, and, most of the crime there happens it is a calculated risk taker. People know that they're not going to cut and they commit crime. But here, mostly I feel like it is a mental illness related, and majority of them are they don't care about the punishment, what happens tomorrow, they don't care. So I was thinking, are we utilizing that information from them, or how, and even in police force, I was thinking, if we can recruit some past criminal in police force or part of the, our advisory committee, and then bring them, not treat them criminal. People commit sometime crime, it is a part of the growing up process also, and little bit become more compassionate to them and bring them in the mainstream so that they can talk about what they are doing, how they are doing, and then not put them like you are different, like you are a criminal, that kind of. So that's just the idea.
So we do some of that. So if we come into contact with an individual that may have, as you said, milk them for information, we would provide that to our investigative unit, and if it's property crime related, we would direct them to that type of investigative unit, auto theft unit or narcotics unit, or even our Northeast Impact team. And we do a pretty good job of working with them to obtain knowledge, and also to work with them to become what we call informants or criminal sources to help us solve or help us kind of build up investigations as we move forward. In regards to providing support services to them, we can do that in a variety of ways depending on their need base. We can direct them to some of our stakeholders and some of our partners through some of the community outreach with our Coast unit, or maybe even some drug addiction type information as well. So we do some of that, and it's in place already. Sometimes we're limited by their type of offense. It kind of we're handcuffed lack of a better term, because based on certain offenses, it's important for the community interest to make an arrest in those type of situations. But definitely a good idea, and we definitely can use, we always, coming from narcotics and spending 10 years undercover, there's nothing better than a good informant and a good criminal source. Provides a lot of information for us. Any other questions I can answer, or any other concerns? Guys, my door is always open. Please come in, talk to me. It doesn't have to necessarily be crime related or anything like that. Come by, say hi. We're open from 8 to 5. We'd love to have you come by, and I know a lot of you do. Come by and say hello, and we do appreciate that. So our door's always open. Contact me when you need to. And always provide information. Always report your crime, because it helps us do our job and to more effectively use our resources. So thank you very much. Thank you, Eric.
Thanks, man. And I think that's a really good point, and kind of a good tie-in to what we're talking about today with behavioral health and mental health, how we can kind of bring all the resources together as a community and stop this cycle of just throw them in jail, let them out, throw them back in jail, let them out. So hopefully that's something that we'll hear a little more about, and maybe more about where we as a community can step in and push our elected officials in that direction, or what we need to do as a community. So hopefully we'll hear some more about that. I do want to give, I don't think we have time for 2 reports on ride-alongs, but if one of you thinks you can talk in about 5 minutes.
I can probably do it in 2.
Okay.
Okay.
All right, you have the floor.
So I rode along with Officer Lawrence Martinez. It was a Friday night shift from 6 at night until 4 in the morning. And I learned a whole lot. I think the one thing that was surprising for me was we had what they call a priority 1 call, and it was classified as a down and out, and it was on San Mateo, and we got there was an individual that was passed out in front of the library, and so there were two police cars. I was riding along with another officer, so there were 2 APD officers. We called a fire truck, and this is basically the protocol that they have to go through when they have these types of calls. So we waited for a fire truck to come. So when the fire truck got there, they woke him up, took all of his vital signs. So there were, I remember at least 4 people on the fire truck. So that's a total of 6 resources that we had. Then once we were able to get him up and make sure that he was at least okay, they had to call an ambulance. So we waited for the ambulance to come, and we were all waiting there. The ambulance came, there were at least 2 people on the ambulance. So we're looking at close to 4, 5, 6, 7, 8 different people, 8 different resources on one call. And so, and we were there probably close to 45 minutes. And so I just thought that was, I'd never been on a call like that before, so it was just an interesting situation. So that was mine.
And I think that's a good place for us to try and shine some light and see where I don't know if it's possible, but maybe there's ways to free some of those resources up to do other. I'm not saying that's not a high priority call, but I don't know
Right.
if we need that many resources on that when they're already there.
Right.
So hopefully that's something we can kind of refer to recommendation and work on. And I think that's something we're going to hear a little bit more about next month. We're going to have, I forget her name, but she's the manager of the Emergency Operations Center. So
Erica Wilson.
Erica Wilson, that's the name. She's going to be here talking about what they do out there. So that's all the 911 calls, 242 cops, and I'm hoping that we can get an understanding from her on how some of these calls are staffed, maybe why a certain call gets 2 officers or 4 officers. And I know I've been on ride-alongs like that too, where you have 4 officers responding to one individual that's maybe doesn't seem very harmful. So it'd be interesting to get that perspective from them also. And if, is that a dispatch issue or is that a
It was
department
just
issue?
interesting that's the protocol that's followed.
So it's good information.
Follow that.
So we'll, if you don't mind, we'll ask you to comment on yours next month. That's okay. All right. So, with that being said, we're moving right along on time here. We have 3 speakers tonight, and we hope that we can kind of make it a dialogue between them, but we don't want anybody to not get a chance to say what they need to say or what they're prepared to say. So the speakers have asked for a particular order. We're going to hear first from Nevin Marquez, and then second we'll have Detective Briones, and then last we'll have Dr. Eide. So, Nevin, if you'd like to take the floor.
Go up here?
Yes, wherever you feel comfortable.
All right, good morning. Go up here. So good evening. Thank you for having me. So my name is Nevin Marquez. I am the Director of Behavioral Health and Supportive Housing Services at St. Martin's Hope Works. And I'm here to talk a little bit about the mobile crisis teams. Just a little bit of background on St. Martin's and some of the work that we do. We are a core service agency for providing mental health services in the city of Albuquerque. We're also a community mental health center. So in addition to being a day shelter where we provide food, shelter, clothing for people who are experiencing homelessness, we also provide a vast array of behavioral health services, ranging from case management services, psychiatric services, individuals who are interested in substance abuse counseling or therapy. We provide that to individuals who we encounter. We don't just provide that service to individuals who are homeless. I think it's something that a lot of people misunderstand about us, is just because we are a homeless shelter and we provide these services, we're not just providing them to individuals who are homeless. So we provide them to pretty much anybody. With respect to mobile crisis teams, so this is an initiative that was started as part of the county tax to provide comprehensive services to individuals who are experiencing crises, an attempt to reduce the rate at which individuals might get arrested for crimes related to mental that may result that may happen as a result of someone's mental illness, to work with officers to potentially reduce the rate at which individuals are hospitalized for psychiatric reasons, and to increase the rate at which individuals are following up with their providers. And so we have been working very closely with the Albuquerque Police Department, who has done most of the training for these officers. So you'll hear from Bonnie, who works at the CIT, and she might be able to kind of talk about some of the intense training that they have actually gone through to get this particular project off the ground. So the way this is designed to operate is that we have 4 teams, which consists of an APD officer or a Bernalillo County Sheriff's Deputy to work with an independently licensed clinician that works for St. Martin's. So their job is to go out together as a team and respond to the priority 1 calls that involve mental health, situations where individuals are a danger to themselves or others, people who are threatening to hurt themselves or hurt other people, and priority 2 mental health calls. So that could be a call where somebody is just having symptoms related to a mental illness, and maybe they need somebody to come out and talk to that individual. So our role as clinicians in working with the officers to go out and address that particular situation, to work, obviously the officer would clear for safety before we enter, to work to de-escalate that particular situation, to provide a basic assessment, and then to be able to provide some level of follow-up service. So the levels of service that we're going to provide can range from requiring or requesting that the individual be hospitalized at psychiatric emergency services, but it could also be something as simple as providing a crisis plan for that particular individual, giving them an appointment to follow up with their psychiatric provider or a therapist, and sort of being on our way. So those are kind of the general gist of what we hope to do. We know that it's a little bit more complicated than that as we go through this. Right now, we actually do have 3 teams that are out there starting today. This is the first time we've had 3 teams actually all out in the field. So they are out in various parts of the city working to respond to these calls. This is very early stages at this particular point. We're working to obviously try to get teams at different parts of the city. Right now this is just the rollout phase, so we're kind of responding to calls anywhere in the city and within Bernalillo County. So that's sort of the general gist of this particular project, and there's been a little bit of talk about it in the news. Some of the things about the training that the clinicians go through. Obviously they're independently licensed, which means that they have a little bit more experience than your typical clinician that's out in the field. They undergo crisis intervention training, the same crisis intervention training that all APD officers undergo. They also get enhanced crisis intervention training. And then they do a series of, right now it's it can be about 4 to 8 weeks of on-the-job training with officers, getting used to working with officers out in the field. That training is pretty much consisted of working with CIT and the Crisis Intervention Unit at APD, and they have been extremely valuable in actually training these clinicians. So we're really excited about the project, and we have a lot of high hopes for it. So that's pretty much kind of the spiel that I planned on giving you tonight. I'm more than willing to take any questions, and if you have a question that I can't answer, I'll try to get back to you. So, go ahead.
I'm just wondering, you say today you have 3 teams. Have you been in training a long time? Has there been one team out? Just clarify that for me.
Sure. So we've actually been training with APD since about mid-December, and of course we've been trying to hire clinicians since that time. So I think we actually had one clinician out there probably about 2 weeks ago doing some preliminary work while the other 2 got caught up. We have a 4th clinician who's actually starting OJT tomorrow. Okay. So we should have a full team of 4 probably within the next 4 to 6 weeks. So,
when your teams respond, and if they find that it's a little beyond what they can handle, does the state or the city of Albuquerque have a 72-hour hold? And if so, where do they go and how does that work?
Well, I think it would depend on the situation. If it was strictly a mental health call and it was beyond something that we were able to de-escalate, in most cases we would, and the individual is still expressing some serious a threat to themselves or others, that individual would definitely be referred to psychiatric emergency services. They'd have to be evaluated by a psychiatrist or psychologist at the hospital, and it would be up to them and the court to determine whether or not there would be a hold maybe even beyond 72 hours a week. Yeah.
Is it eventually planned that this will be a 24/7 operation?
Right now what we're looking at is preliminary data that has been collected around the calls, and so what we're sort of seeing is that there are some peak hours whereby individuals are calling 911 or officers responding to those particular types of calls. So right now what we can gather is that we're open 7 days a week, but we're not necessarily sure we need to be open 24/7 at this point. As the morning hours begin to approach, the number of calls for this kind of stuff tends to be reduced significantly.
Am I correct in assuming that when somebody calls 911, that whoever responds, the operator responds, has a protocol to help identify if these are the type of calls that are part of your program?
There is a protocol that is being worked out. Obviously, this is a new project, so we're working through a lot of those. I can tell you that when we first started, we were getting very little calls, and as we have begun to roll this out, we're starting to see those calls coming in. So they're working on it, and we've been out there talking to as many people as we can to get ourselves out there so that everybody knows we're there.
Thank you.
Is this program, are you building upon what other cities have done, or are you taking the lead on it? How does that work across the country? How do we compare?
Sure. So there are a number of different models. There are some models that whereby this model is where police officers are actually, clinicians are embedded with police officers going out to calls. So there are other models that involve clinician that's involved with emergency services or the fire department. There are other models that are more hospital-based. So somebody will call for that they're in crisis, hospital worker goes out, and then the officer will show up, clear the scene for safety, and then the clinician kind of goes in. The models that we're basing ourselves out of are basically in Houston and Los Angeles, which are the models that where an officer is embedded with the clinician, or the clinician is embedded with the officer out to the scene directly.
Okay, thanks.
Who are you responsible to reporting your outcomes to, and how do citizens find out?
So we actually have a report that we have to submit to the city of Albuquerque every quarter. And so you can actually get that report from the Department of Family and Community Services every quarter. Yeah.
Hey, I'm Paul Killebrew. I'm from the Department of Justice, and so we're just visitors here, not residents of the Northeast community, but I'm really happy to hear this information about the mobile crisis teams. It's an exciting development. One question I have is about how the chain of command works for the officers who are on the team, since it's both BCSO and APD. Who oversees the mobile crisis teams? Who do they report to?
Sure.
Are they based centrally out of like the Family Advocacy Center? Are they based out of the area commands? How does all that work?
Well, you've asked some really good questions. As I understand, I can tell you that St. Martin's is in charge, and we work with the clinicians, and that's who they report to. Obviously, we report to the county and the city in terms of what we're supposed to be doing in terms of what our outcome protocols are. In terms of chain of command, my understanding is the APD officers will follow their same chain of command. They will report to their sergeants and their commanders, and the same goes for BCSO. So you can imagine that we really have to work very hard to work together because we're all very different agencies and we all have different protocols and procedures. So far, I think we've done a pretty good job in working it out, but it takes a number of meetings to be able to get there. Does that help?
Yeah, I think one thing that pops in my mind just in terms of seeing this within the context of the overall reform effort is this is an initiative that for APD's purposes is going to help them come into compliance with some of the areas of the consent decree that deal with mental health issues. And so, but to get there, we're going to need to see some architecture. So what is the policy that defines the obligations of the people who are in the mobile crisis unit? What is the reporting structure for them? I think the coordination among the county and the city to create these things is great, but it does create some questions about where are the lines of authority and who reports to who. And so eventually we got to figure all that out and make sure it's documented and that it sort of satisfies all that what we would be looking for in terms of accountability from APD.
Sure, and I think right now APD has actually developed some specific policies towards mobile crisis teams, and I think that there are going to be things with this project. If it's not us and another agency is contracted, that we're going to these kinds of questions are going to come up, and we're going to have to work through them. This being a new project, already lots of things that we've had to kind of work through, and I imagine this is going to be a very organic process going forward.
I have a question over here. Sure. As far as recruitment of, we know that APD and to a lesser extent BCSO have trouble recruiting officers. What about recruiting clinicians?
Well, I can tell you that it's not your typical 9-to-5 job for an independent licensed clinician. I think one of the issues that we've had around recruiting are the hours. We have had a lot of applicants. We've had a number of people that are interested in this particular type of position. And I think that the issue is the hours, and we want to try to put people on a rotation so somebody's not always working every single Saturday or every single Sunday, but it sort of can be luck of the draw, and so people are sometimes looking for that typical 8-to-5 shift, and I think it takes a very special and dedicated person to want to work on the mobile crisis team.
Are you going to also do some kind of a focus on people who are chronic 911 abusers who constantly are taking the time of the system and not really realizing what is a critical 911 type call versus a non-emergency call? And is it more than, how should I say, average, that they've gone off their meds? And what if they run out of their meds? Will you facilitate them getting meds?
So, you asked a couple of interesting questions. Yeah, I think that we believe, we're not sure yet, but we believe that we're gonna experience seeing the same individual over and over and over again. We believe that probably happens. To the extent to which it's actually occurring, we're not quite sure yet. In terms of those individuals that we're seeing on a regular basis, part of our goal is to not just go out and de-escalate the situation or send somebody to a psychiatric hospital. Our goal is to really try to connect them with the service array. So if they're not taking their medications, we want to be able to work with the hospitals. We want to be able to work with their providers to figure out a way we can actually connect them back to those providers that are providing those services. Because we believe that's really the best way that we're going to stop that cycle from happening.
If they run out of their meds, is there a means by which you can assist them in getting
So,
their meds so they become
I
more
think,
compliant and less problematic?
We have actual programs at St. Martin's where we have a psychiatric nurse practitioner that's there to provide medication services to clients. But we're obviously not the only one. And so clients that are out there that are on meds, typically they have a provider. And obviously we want to work the best we can to try to ensure that they're getting their medications. And that can involve case management. We do medication monitoring services where we actually have the clients come in on a weekly basis. We do injections for people who have a hard time taking oral pills. So there are some things in place that can address those types of issues.
Is there a protocol for confiscating firearms?
That would not necessarily fall into the realm of mobile crisis teams, like the clinician, but that would definitely fall in the realm of officer safety. And so that would be up to the officer that arrives on the scene to deal with something like that.
Well, given today and what's been going on, we're talking about people that may be at greater risk of doing something not good with a firearm.
Sure.
We have a president that's calling for just taking them without any due process. But sure. So I was wondering if there might be a protocol with due process.
We don't have a protocol. I mean, we don't necessarily have a protocol at St. Martin's for disarming individuals, and I would have to refer back to what APD or BCSO does in those particular situations.
So then that's a question for the commander, I guess.
That will be a better question for you.
About taking away firearms?
Yes.
It's, it's a process that, we have to be able to respect the individual rights of every individual person. And with a subject that is in crisis, we often will reach out to our crisis intervention unit and use them as a resource to help facilitate and negotiate them relinquishing their firearms for safekeeping until they become stabilized.
Voluntarily.
Yes.
So I think that's a good segue. I want to make sure everybody has enough time to speak here. So since we're bringing up CIT, Detective Briones, if you want to jump in.
Thank you, Nevin.
So I'm Briones. I'm one of the detectives for the Crisis Intervention Unit. Briefly in speaking with Ani. She kind of wanted to go over kind of how the structure is with APD's Crisis Intervention Unit. We fall under, our unit is very unique. We fall under the Compliance Bureau, and we are in the Crisis Intervention section of things. We have a lieutenant, a sergeant, and then we are mandated and staffed for 12 detectives that work, and I'll explain their functions here in a second. Right now we're at 11. We're working on that 12th spot here shortly. We have 5 coast specialists. They are civilians and they work alongside of us. We have 2 full-time clinicians that work and go out on calls with us. We have a full-time psychiatrist that works with us that can go out on calls. And mobile crisis teams, and their training has also come straight to us. Like Nevin was explaining, yeah, because of the BCSO thing, they fall under BCSO, and then the APD officer, we only have 1 officer right now that's doing the mobile crisis teams for APD. They fall under us. The way that the detectives are broken down, we have home visit detectives, and what happens there is officers will go to these calls, your frequent calls for service, people that are identified that call 911 frequently, escalating behaviors, danger to self, danger to others, something that might get the officer's attention, threats made to others, Say, for instance, is a threat that I'm going to so-and-so is going to show up at the courthouse and shoot their significant other. And it's a behavioral health crisis. We go in and start investigating that. That's the home visit side of things. The home visit side of the detectives will take a clinician with them, and they'll actually work and kind of follow the person. Where mobile crisis teams are going to be responding to those hot calls, and they're going to be those ones that are engaging in that kind of element of crisis. The detectives are the ones that get to do the follow-up. They're the ones that get to do the rapport building. They're the ones that establish the relationships in the community, like with MDC. They're the ones that paint that picture with having meetings with Presbyterian, Loveless, anybody that might be a mental health provider, and they kind of create and bridge that gap to get the services needed. We're excited and so excited to see mobile crisis teams work out, come online, and like Nevin was saying, it's brand new, so we're all just filling out the kinks at this point. Home visits, building that rapport, and kind of working with that individual, they actually get to learn a lot about the person. They learn about the family members. They learn about what they like, their do's, their don'ts, topics that officers should avoid, topics that officers, if they have to respond to the call, they can use to help foster that positive relationship and kind of that positive outcome that we're looking for in calls for service. So I think that's a great thing that our detectives do and strive. We get very close with our clients. Dr. Eide will tell you there's a couple on my list that I will be extremely passionate about and defend to the end, even if they're in the criminal justice system, which is kind of fun for us because we kind of follow these people in our journey together. We get to know, I have a mom right now that texts me all the time, and she texts me because she's out of state and her son isn't getting the resources here. So we built that relationship, and that's what we do in the home visit side of things. It's very unique. If somebody needs to go to the hospital, we'll take them to the hospital. If we need to get them to jail, if they have to go to jail, that's okay. Because while we do push and promote jail diversion, which is a great thing for us, at the same time, we do utilize the criminal justice system at its peak. Fortunately for us in New Mexico, the best mental health hospital is MDC. And I hate to say it that way, but you get mental health plus you get substance abuse and substance use disorders at the same place. There's a huge void when it comes to our state, when it comes to our city, when it comes to that area of things. And utilizing and making connections with our community providers and MDC and everybody like that is a straight shot where I can pick up my phone and call Dr. Eide or whoever's at the jail and say, hey, you know what, I got so-and-so, he's going to jail. Can you please take care of him, make sure he gets treatment, make sure he gets the help he needs. He's homeless, needs housing, and fostering that relationship as well. On the other component, we have our training side detectives. These detectives, there's 4 of us, and these detectives take care of all the training. That starts from the cadet side of things. We go through officer training, that's our 40-hour crisis intervention training, which is the entire department. Every officer in this department is crisis intervention trained. We have enhanced crisis intervention officers. That's an extra 8 hours, which also combines with barricaded subjects, how to engage with somebody on a high or elevated type of suicide situation, and a couple other subjects that are beating off of my head there. But this extra 8 hours is 40% of our field officers. These are 40% of our field officers are enhanced crisis intervention trained officers. So where we have 4 mobile crisis teams, we have 40% of the department that are enhanced crisis intervention trained officers. We have 8,000 calls for service that are behavioral health related in this city every single year. And that's just going up. 8,000 calls. And I can't tell you how many times they're related and they're co-occurring with some sort of substance abuse. So that's a huge issue for us. So please rest assured that, yes, we have mobile crisis coming on, but we also have these officers that are willing and able to take these calls for service if they come up, even if we can't get the mobile crisis teams there. We want them to get there. Enhanced crisis intervention trained officers are officers that volunteer for this. They're not forced, they're not asked to do this, they're not anything like that. They are people that want to do this. These are the officers that want to make that decision, that want to engage with somebody who's in crisis. These are the officers that have a passion for it, and we look for that. We really want passionate people who want to engage with these individuals. Because while there's a crisis and while people living with mental illness, have bad days and good days just like all of us, there should be somebody passionate enough to kind of be that liaison and bridge between law enforcement and the crisis. We also have our COAST team, COAST professionals. They are our crisis specialists. They're civilians. We have 5 right now. We have an open vacancy because we have 6 area commands. These are ladies and gentlemen that are civilians and very dedicated to finding all the resources in the community. Where can I find resources to help so-and-so? And they will, if I need somebody a food box or if I need to bring somebody some sort of resource, that's where they step in. They come in and come alongside. They're also going to take our lower level calls and follow up because they have 2 detectives that are assigned to them. They can also do home visits on your lower level frequent users of 911. So they're also there helping and coming alongside of them. We have a data analyst that helps keep us on track. That's where I'm getting our 8,000 calls from. He keeps track of everything. Actually, I have him doing a project right now for me looking at all of our high element jumper type calls. We're trying to avoid using the word jumper because it sounds stigmatizing for that person. But at the same time, if I want a project done through him, he can come alongside me and point me in the direction and pull all the data that can come out of the real-time crime center, and we can use that. If there are problem children in the neighborhood that are escalating in calls for service, crimes, anything like that, that's where our team will come in and kind of build that bridge and kind of network as much as possible. Like I said, we have the training side of things, COAST. We also have a person that does a lot of our liaisoning throughout the nation. She's really good. She's a civilian. She will go and find best practices in linking us to having webinars and law enforcement only webinars with Virginia. I think we had some people from Oregon. We had a couple other people that kind of come together, and we kind of get feedback on calls for service. And this is a great place for officers to come, and we encourage them to bring their issues if they felt like they did poorly on a call, if there's a mistake they feel. We want in this closed network area for officers to discuss this. And the reason for that is we want that open line of communication with each other. If we can't be honest with each other, then what are we doing in law enforcement? And I think that it really does a great service to the officers that are involved, because now we can bring our problems, our mistakes to each other and say, you know what, I didn't do well on this, I feel like I could do better. We had to tase this guy last time, but let's talk about the situation, how it unfolded. And now we're talking about the situation, and a couple weeks later, hey, you know what? Came in contact with the same individual. I tried the de-escalation techniques that we talked about. This is a better outcome. And so now we're seeing a lot of that. And our unit is very proactive in that area as well. So there's a lot of things that are going on. We've just started de-escalation training on the training side of things. We're going to be teaching, I think we're going to city council. We have a library. We're going to be talking about to the library. I have a liaison with the pediatrics residents that I'm going to be teaching with them. So working with them and the staff is really trying to build that community effort and a lot of what's going on. I'll say that our unsung heroes are definitely your home visit guys. They will build a bridge between any and everybody just to get them the help they need and make sure that they're in the right position. So that's kind of a breakdown of our unit. I don't know if there's any questions. Yes, ma'am.
Are you the unit, or is there a unit that someone can make a referral to before a crisis has happened, so that you're aware that that individual is out there? And how do we find out about doing that, like for a family member? I mean, can family members call and say, I have a son who's schizophrenic, and I want someone who knows knows my son, so that if a crisis occurs, that person's on site rather than someone who isn't trained with them?
That's a great question. There's a couple things to that. Yes, we do take referrals from family members. We have an on-call detective at any point in time. So you can call 924-6000 is the Family Advocacy Center number. You can call that and ask for the on-call CIT or crisis intervention detective. And with that, we will try to foster that relationship with the person prior to crisis. If the crisis occurs and officers have to be called, what the family member can do is we can put information on there that an ECIT officer, an enhanced CIT officer, trained officer should go out there and talk to that person. We can't always guarantee that we can go out there, but we do pay attention to the calls for service. We do get hits on our end. By hits, it's not a negative thing. It's we get alerts, I guess you will, if officers go out with one of our people based on the real-time crime center, so we can follow up the next day. So we get those all the time.
Our CAD system keeps some of that data, and we have a couple of individuals in the Northeast Area Command that will actually, when they're in a crisis situation, they'll ask for a specific officer to see if they're on duty because they have built that rapport and have that comfort in dealing with that officer. So we do have that available to us through our CAD system.
And you know, but one thing is, I don't think the public knows that they can do this.
Well,
That's
we're
what
working
needs to
towards
be.
that.
So how are you going to let the public know that there's this available, like public service announcement, that there's this is available for people with mental health issues and their families?
A lot of providers will link people and families of concerned family members to us. I know that if there's a concern at MDC or if there's a concern at UNIT Mental Health, we have a memorandum of understanding working with them that they'll actually bring them to our attention and say, hey, you guys should follow up with this person. So we try to foster as much public awareness as we can to that. But we also don't want to put out a very stigmatizing list, if that makes sense. Because here's what I think. Here's why I'm saying this. Okay, if I'm living with PTSD, okay, and I have bad days, okay, and if I'm living with PTSD and I'm gonna have some bad days, and my family are the closest people to me, and I have a bad day with them, and now they want to put me on a list or in a system or something like that, that can feel very damaging and almost make me want to feel like I'm kind of categorized. Now we've put them in a category, and and for me, and with dealing with a bunch of people that I deal with, you know, they want to be treated as if that illness isn't there. Yeah, we talk about bad days. We talk about, hey, you know, are you having a bad day? Are you having a good day? We try not to stigmatize that, you know, person's living with mental illness.
What I've heard you say, though, is it's okay if a mental health provider does that, and it's okay if MDC does that, but the people who know them the best, possibly in the community, is stigmatizing them.
No. I apologize. That's what I meant. That's what came out. But I don't want to create a list of people that have mental illness issues just because they have mental health issues. If you're concerned about somebody who's in the community that is living with mental illness and is potentially a threat to themselves or others, and then we can start fostering that relationship. Does that make sense? Does that make
that's
better
what
sense?
I'm talking about. I'm not talking about being mad at somebody who has PTSD.
Yes, sir.
Hi. The recent shooting at the Florida high school, apparently there had been multiple home visits by law enforcement, and one of the issues that came up was that they knew that there were weapons available to this young man. What happens when you find something like that?
So if we get a report or a call, or usually they come in reports from field officers, what we do is we start automatically doing a background on the person. From there, we'll arrange and call and try to validate that threat. A lot of it is validation because we want to know if it's social media, what social media is being used, because some of it disappears in 30 seconds. We want to look at all those things and validate that type of threat. We also want to look into mental health. Is it driven by mental health? If it's not, we need to figure out why this behavior is starting and where this is stemming from. Our unit does do a lot of that, but now we're seeing that the impact units, our impact detectives, are starting to pick up and start investigating that because they are taking it very seriously. Our unit does not charge anybody. We don't pick up people for warrants. We don't charge anybody. We show up at your door. You know that we're a friendly face. Impact detectives in the area command actually will go out and charge somebody if they start making those threats.
Okay. So you're like the first responders in that sense, in that chain, right?
We're the follow-up. We get the first responders show up, they validate that initial report, and then we come out afterwards. So we're kind of that follow-up.
Do you ask whether or not there are firearms in the home?
We always ask if there's firearms in the house if it's directed towards a threat with a firearm. We try to stay on the constitutional. Everybody has constitutional rights. And until their constitutional rights are taken away by a judge, mental health, mental commitment, like they're involuntarily mentally committed to New Mexico behavioral health up in Vegas, we try to allow them every freedom that they're allowed. You know, if we do ask about firearms, but if it's in the process of our type of investigating as far as this is a threat by a gun or this is a homicidal threat, if there's something like your neighbor's threatening to kill you, okay, do you have firearms in your house? That's a different sort of situation. So, does that make sense?
Yes, I was just wondering if there's any point in that process where somebody will say, this person is obviously schizophrenic or has a mental health problem, and they've said that there are AR-15s in the house. Is anybody authorized to pick those up temporarily?
We would need a warrant. We would need a warrant to get that firearms out of the house.
Does anybody ever go to a judge and seek that?
Yep, some do. State police did on one a couple months ago, and it was denied. And it was a threat on the governor. So, I mean, it just depends. So, I know there are detectives out there that go and foster that, but we want to stay by their constitutional rights, write a warrant, and make sure that we go and get those. But getting a warrant just based on behavioral health and threats like that, unfortunately, are very hard. We can't just go seizing guns.
In and of itself isn't a reason for seizure of a weapon. We have to corroborate all the information that was provided, whether it was through social media, and that's why we direct that to our area command impact units. So if we know that they have the resources and they have the investigative skills to research all that information, and that's why it's at the area command level. If it's at a school, we have a protocol that we immediately reach out to our school resource officers in that area to alert the educators, as well as to alert APS police as well for their assistance. And then the area command investigative units will follow up and substantiate all the information involved. And if there's enough information, they will seek an opportunity to get a search warrant to seize any type of firearms. In my investigative unit in the Northeast, we haven't had that situation yet.
So I want to keep moving through the cycle here. So I want to keep things on track. So thank you guys for your questions, and certainly if you have time at the end, feel free to come back to any of the presenters if you have a specific question for them. So, Dr. Eide.
My name is Dr. Carla Eide. I work at Bernalillo County Detention Center. I'm a clinician, not an administrator, and I'm going to focus my talk mostly on how people get care or how they're denied care, or the obstacles we have in actually getting people care and leveraging the care that we give at MDC out in the community. So I was actually originally an engineer, and I'd always wanted to go into medicine, so I went into medicine a little later in life. I started out in internal medicine in San Francisco, and then I did my psychiatry residency at UNM and a fellowship in geriatrics. Believe it or not, I used geriatrics at the jail. The oldest person I've had out there was 99. He violated a restraining order. And so I actually started out there, was an attending there, and then one of the people that I actually worked with at UNM went to MDC and said, why don't you come out and work here? And I was actually going to head home to California. This was like about 10 years ago. And I said, oh, I'll come out and work for about 6 months. And I've been there ever since, because guess what I found at the jail? All of my patients. I was an inpatient doctor, and I was on the geriatric unit. And so most of the patients that I saw that had severe mental illness, I ran into him at the jail, and so I've pretty much been dealing with him ever since. So the people that I'm most interested in are people who actually, there's no avenue to the justice system except mental illness. Those are the folks that I have tried the most to focus on. So once we got out there, I realized that actually, whether they want to call it that or not, MDC is a community mental health center. We just happen to be embedded in a jail, and we should be treating it as such. So, so we started connecting more with the community. I connected back with UNM. We worked very closely with the Koch Clinic. We worked very closely with Dr. Maria-Lynn Arizaga at St. Martin's ACT team. And we started having people out. I just basically started inviting people to get out. The Koch Clinic came out, then we discovered CIT. CIT started coming out, and CIT started coming out particularly for one patient, but then it expanded to come out on Fridays to go to groups on the PAC units, or the psychiatric acute care units, so that they could work with people, develop relationships at the jail, so that they knew them when they went out. Because so much of what we've done and so much of what's easier for me now is because I've had these people for years. Some of these people I took care of at UNM, and I've continued to take care of at MDC. I know them and I know their families. So once we did that, then we went out there. So the MDC folks went out to a Koch Clinic. We went to Healthcare for the Homeless. And so we started to develop, essentially to travel in a pack, if you want to put it that way. So we had CIT, we have the public defender attorneys, misdemeanor and felony, who actually are part of my treatment team. Since I don't have a treatment team in the community, my treatment team is attorneys and police officers. My experience has been in the community, if there's 10 reasons, 50 reasons, 100 reasons to take care of these people, and 2 reasons not to, they will hang their hat on the 2 reasons not to. The police and the attorneys, there might be 50 reasons to not do it, but the police, actually the most helpful people, whether they get credit for it or not, are the CIT folks, because if there's only 1 or 2 reasons to take care of them, they will choose to take care of them. And so we have a much closer relationship with CIT. The Koch Clinic is, if you don't know what it is, it's the UNM. It's basically specifically for people who have mental illness so severe they have a thought disorder. So if you have schizophrenia or bipolar, by the nature of those illnesses, you have a decrease in executive functioning. Schizophrenia used to be called dementia precox because people were psychotic and had a bunch of other symptoms, both negative and positive, and then they developed dementia. So these people who are on essentially a downward spiral of having cognitive impairment, sensory impairment, and executive function. So once we got all of this stuff going, including getting drug reps, we have drug reps coming out to the jail, so we can start people on long actings at the jail, and then transition to the Koch Clinic. But what I found out is that we would get people doing so well because we actually had time to treat them. At UNM is painfully, agonizingly undersized and understaffed for the community. I mean, if you think about it, UNM was originally a casita. So UNM was built like 45 years ago when there was 2 powerhouse state hospitals, Fort Byrd and Las Vegas. Neither of those really exist as state hospitals anymore. So now you have UNM. UNM was never meant to be a workhorse. It was never meant to be a powerhouse standalone. It was meant to be a community center where the people who were either violently mentally ill or severely mentally ill requiring long-term care had those alternatives to go to. They also had group homes, which we almost don't have in Albuquerque anymore. You have board-in cares, which range from being sort of moderately okay to just really almost predatory. And none of them are actually, I don't believe they fall under any sort of supervision. So UNM is very undersized. UNM can't keep people. So one of the nicer parts of actually working in the jail is I would actually get to keep people long enough to get them well. So healing somebody who's having a psychotic episode or is decompensated with bipolar, it's not something that you turn, it's not like cutting your skin and then your skin heals. You're talking about long-term regulations of receptors, neurotransmitters, all of these things. It takes a long period of time to actually heal. So what I discovered is one of the only places in the state where that was going to happen was at MDC. So we would try to bring what we were doing, just exactly what I was doing at UNM, tried to do it exactly that way on the PAC units at the jail. And people were there long enough for actually to get them well. We saw people who never smiled before, people who had very flat affects. You started to see them smile, engage, interact, have an interest in working with people on the units. And so it became that kind of a resource. But then over and over and over, about 5 years ago, we would turn them out to nothing. There was no place for them to go. If they were there long enough, their benefits ran out. And now we're trying to get their like Medicaid and Medicare started, but there's no place for them to go. So we can spend a huge amount of time finally getting people going well, and then we have to turn them out to nothing. Because it takes 30 days to get them any sort of funding to go to any kind of housing, and often that housing is one of these boarding cares. So one of my mentors when I was at UNM used to say psychiatry is the art of stating the obvious. And the longer I do it, the more I think that that's true. And the obvious is, unless you meet the need, you haven't met the need. So until you actually look at a problem and solve the problem, you haven't solved it. And so what we have over and over again is half measures and what I call the appearance of care. We have to fill out a discharge plan. But if the discharge plan is for somebody who has severe mental illness and has executive dysfunction, saying follow up at healthcare for the homeless, or I might as well say, go camp on the West Mesa. I mean, it's not, the level that the discharge is so far below meeting the needs of these people, it's almost as if it's really not much help at all. So if you ask why these people come in and out and in and out and in and out, we can send them to UNM. UNM doesn't have space for them. They can't keep them for any length of time. So they might go there, the family might be calling and telling me, I'm terrified of this person, I think they're gonna hurt me, I can't tell you how many families I talk to have bolts on their doors, remove all the knives from their house, live in terror because they think their son or grandson's gonna hurt them. And so, but they'll go out, they'll go over and say, hi, my name is Bob, I live in Albuquerque and I'm not gonna hurt anybody. And they'll say, wow. They'll call the family and say, why don't you come and pick him up? Bob says he's not gonna hurt anybody. And so, again, they go home again. So most of the danger, most of the problems is actually dumped on the family members. And this is the part that I think is the most tragic. There's layers and layers of tragedy here. But one of it is that the families can't keep them. The families might love them, they want to keep them as long as they can, but eventually they'll say, I have grandchildren, I have other younger children in the house, and I can't keep this person here safely. And you have another homeless person born. If the rest of the family won't take them in, or if they don't have money to send them someplace, which they don't. And so a lot of the cost of this is absorbed by the families. They lose days at work, going out looking for them, trying to support them on the street, trying to put them in hotels. And when these people end up with drug issues, it's, being home, it's like you're gonna run into drugs. There's just no way around it. It's like getting dirty. They're gonna be dirty, there's gonna be grit, and they're gonna be exposed to drugs. And so that's where about 5 years ago I actually started running around doing this sort of stuff, because it was so frustrating and so heartbreaking to get people actually doing well, and have invested a huge amount of money, and the one thing that most other people don't have, which was time, and then not have any place for them to go. And so, and sadly, that's kind of still the same place that we're in. There is more, I think there is a shift happening, but, and there's gonna be like a small, like a 5-patient trial program going on with UNM and heading home to take some of the higher utilizers. But again, those higher utilizers are not often the people that I'm talking about. We've had people at the jail who are schizophrenic and basically legally blind who refused to leave. We had to evict them from the jail. One of them got stabbed downtown. I've lost more people than I can tell you. Stabbed, shot, overdose, froze to death. Homelessness is not, there's a lot of services for them, but if you're somebody who's already impaired with mental illness, it's a horribly hazardous place to stick somebody who has weaknesses and vulnerabilities. So the way that I often explain this is, if you take somebody, so if I'm trying to send somebody out from jail, a normal person might be here. Say, this is what their IQ is and this is what their functioning is. There's actually very good studies that show even any of us who may not have a severe mental illness, if you make them homeless and you have chronic homelessness and chronic stress, you're going to function around 10 to 12 IQ points less. If you have a severe mental illness, you have cognitive and executive functioning impairment. After the first 1 or 2 major events, you will start to have a decline. So then you're down here. So if you have somebody with severe mental illness, if you add medical illness, some of these people are diabetics, have other medical illnesses, now you're down here. If you add drugs, you're down here. So almost all of our discharge plans should actually be set for people who are borderline intellectual function, because we're taking people and we're putting them in that situation. And almost none of these are. So when we try to do a discharge plan, there's nothing out there for them. We try to send people to the state Department of Health, no help. The state hospital, absolutely no help. They range from being dismissive to obstructive. And so this goes on and on and on. It's a very, very heavy lifting to try to get some of these really sick people care, especially even if we know them really well. Then I went into transition. We tried to get guardians if they really met criteria for guardianship, because it was a way to actually have somebody kind of glue services to them as they went out the door. But then, of course, the Office of Guardianship has had its issues as well, and there's like a 6-month to 2-year wait list to get a guardianship for some of these folks. So that's kind of what we're up against. We still try to do as much as we can out there with the new sentencing thing. We don't get to keep people very long anymore. So now there's a much more in and out, in and out, in and out, in and out, because there's no place in the community, but the jail isn't allowed to give the same sense of services. Yeah.
I imagine that a lot of the mental health inmates have never had any sort of drug treatment, psychoactive drug treatment, the schizophrenics, Thorazine, things like that. Are you in a position where you can start them on a regimen?
Oh, what I do, what I've done in the past in NDC, I mean, I've transitioned in and out. I've like half in time and half doing telepsych now. What I did out there was the same thing I did at UNM. I got a treatment guardian. If they required it, I got them a guardian. We will start them on meds. The standard of care now is to get people on long-acting injectables. And so I will not start them unless I have some place in the community for them to go. So essentially, they're going to go to the St. Martin's Acting with Dr. Maria Lynn Arizaga, or they're going to go to Dr. Abrams at the Koch Clinic. There's very few other places in town that will do it and will follow them. So if I present them to those 2 places and they're accepted, then I will start them on long-actings. The only one I can't start at the jail is long-acting Zyprexa, which is Relpred, because you have to have a site license to do it, but we're working on that. We did have drug reps for Abilify Maintain, Aristada, and for Invega, so that we were able to start that without having it be at a cost to the county or anybody else, but we could start them at the jail, and then we could try to follow them up out there. But again, we get tripped up because there's no place for them to go. These are people who originally would have been in very high-level group homes or in a state hospital. And there's no way that a homeless shelter was never meant to be a state hospital.
Well, it's pretty well established, and this is nationwide, that the correctional facilities are now mental health centers.
Yes.
For the country.
Yeah, the numbers of people at the jail have gone down, but the severely mentally ill are still there. And their families are still calling. I mean, I can't tell you how many, if you just got dropped in New Mexico, the people that I talk to, you think that there was a predisposition towards sobbing on the telephone for middle and elderly Hispanics. I have people calling, their doors are shut in their face. They try to take them to UNM. UNM says they're not sick enough. But the problem is when you have an expanding community and you don't have expanding services, the services are run by human beings, and they basically get to the point where they're just defending the service. So that's where you get if there's one reason to not take them, they won't take them. And so it becomes harder and harder to get people evaluated. It becomes harder and harder for people to stay there long enough. Getting a shot in the psychiatric emergency services and being sedated is a very expensive bandage. It doesn't help anything. Sending them back out to the street. They do this over and over again because there's no place for them to go. Having people who stay in hospitals for 7 to 10 days, it's not enough to get them well enough. If they can wake up now and say, hi, I'm Bob, I'm in Albuquerque, and I'm just fine, I'm not hearing or seeing things, out the door they go. They're not even close to being stable. It's the appearance that we're hanging our hat on right now. And so what really has to happen, there needs to be a safe place for these people to be where they can get well. They need regular sleep. They need to be in a temperature-controlled environment. They need regular nutrition. And basically none of that stuff are they really getting out on the streets. And that's where they're going.
So have you seen any kind of proposal or model in another city or country that meets that criteria? I mean, what do we as a community need to build? What has to be?
I mean, again, it goes back to meeting the needs of those people, and they need real group homes. You need a real group home. They need people to actually hand them their medications and know where they are and get them places. And they need to have places where they can stay long term. And once you get them well, keep them well. That's the most frustrating part about this. There's a huge amount of money being spent here. It's spent from taking somebody down here up to here, but there's no money spent in keeping them here. So essentially, it's a very inefficient system, and that when you have somebody who's really ill and you've gotten them well, in a way they're almost like a resource, because now you want to like maintain that resource. But if what you do is take somebody you finally got well and dump them on the street, it's not that you've wasted all of that money, but you certainly could have done a lot better preserving the result that you got. And I think that's frustrating on both an economic and a humanitarian level.
So how do you maintain your motivation and positive attitude when you know that so many of your patients are going to be released without a place to go and without a plan?
I actually don't know. I'm pretty much a zealot, if you want the gospel truth. So, but I keep thinking that somehow or another, if we can get just enough services, enough meds, and get them stable enough, we'll eventually get a place for them to go. So that's my job. My avocation has been to try to get one patient care. And I've been trying to get him care for 4 years now. I have his guardian's permission to actually discuss him. But he's been my avocation because he's been banned every place in Albuquerque. We actually got him to the point where we could have had him committed to a special facility in Los Lunas, and the state refused to do it. We begged them, we went up and down, we did everything possible, and then we did get him up to Las Vegas, but there's no place. They brought him down and they took him to a clinic with a prescribing psychologist who does couples counseling. I mean, that's the appearance of care. That's not really care, because that's so far away from anything that would be helpful for that individual. I'm also at the point where I'm just going to do like a GoFundMe account, see if we can find an attorney who can help us, respond to what the state's throwing at us, because we're pretty much at an end of how to get this person care. I'm almost positive he's somebody who's at such a high level of being killed on the streets of Albuquerque, and everybody knows this. But we have no way. His mother is elderly. She doesn't have any money. It's hard to hire a lawyer if you don't have money. But we've exhausted everything. I've begged, borrowed. There's too much obstruction to getting care. And the other thing is that nobody will care for these people unless they have to, which is why it's a jail. It's heavy lifting. You really have to like the patients. You have to really value seeing them grow and benefit from this. And it's a lot of work. And it's a lot, and to some degree, if you're just locked in this cycle of getting everybody better, it's a lot of money. It's still a lot of money to try to keep them stable, but I think it's less money than continually picking them up off the floor and dropping them on the floor again.
And some of you have heard me discuss this, and Dr. Eide and I have talked at great lengths about, what are some examples of what other places are doing. And in 2013, I traveled up to Italy. They have one of the best behavioral health systems in the world. And the recidivism rate is 27%. And I went out to see a psychiatric ward, and what they're doing there, and Spain is actually modeling what Italy is doing. And I went out to Spain in 2014. But what they're doing is they kind of have this system where before folks are transitioned out of being incarcerated, they actually are placed into these homes, as Dr. Eide was kind of saying. They're homes where these folks can actually live a productive and healthy lifestyle. And these are folks who suffer from severe mental illness. So when we talk about mental illness, I think a lot of folks talk about schizophrenia, bipolar. A lot of times we refer to that as severely mentally ill. And I saw individuals who if we were to see those folks here in our own community, they would be homeless. But when I saw them into these, they had apartment units, where even the hallway were painted certain colors so that way they could remember where they lived. In the morning they had tasks where every morning they would go to the kitchen, they would help prep breakfast, everyone would take their medication, but they lived independently. And it was a beautiful and a very dignified way to see treatment happening. But it also saved a lot of money as well. And so I think there are some really great models that we can use, and those are policy-driven models. And I see Senator Tallman in the back, so. But I think there are some really effective ways. And then just the last piece, I think when we're talking about firearms, it's important to remember that mental illness, you don't need to have a mental illness to experience crisis. Any one of us in this room could have a crisis happen to us. 1 out of every 4 Americans will suffer from a mental illness at least once in their lifetime. So I think in terms of how to utilize the resources you've learned about today, where I have is Facebook. If you see someone who is threatening something on Facebook, if you know of someone who has threatened, harm to themselves or others, these are resources that I have actually used for folks that I've been worried about, where I've called and I've said, this person posted such and such on Facebook, and the crisis intervention team was able to go and do a welfare check and go check on this individual and have actually saved lives. So I think if you learn the appropriate ways how to use these resources, which is why we're hoping we're hoping you learn today, I think it's one of the first steps, but it's definitely a dialogue that we want to continue having about this, because I think that there are we're moving in the right direction, but I think when we talk about funding and how to put those mechanisms in place, we're not connecting the dots, and I think there are some ways that we can do that as a community. But what I saw in Italy and Spain is it's very community driven. It didn't come from someone at the top saying, hey, we need to have this. It was demanded by community members, even to the point where now the policy is they have their behavioral health in their hospitals in the center of the community to ensure that everyone can have access to it.
And that's where we all come in. I mean, we're all here for some reason, but they all really relate to crime, and we can talk to any of our police officers and they'll tell you that the vast majority of crime is related to mental illness and substance abuse. We have some resources available, but clearly they're not adequate. We've talked about this many times before. The state legislature just met. I know that they earmarked a lot of money for school security. I think that's a great thing. But are we attacking an appearance, or are we attacking a problem there? And so I think we as citizens have to make those hard decisions for our legislators and our representatives to make those decisions. They're hard decisions for them to make. They're going to cost money, they're going to cost time, they're going to cost political capital, but we have to be involved in that or it won't happen, because they're just not going to take that step without our involvement. So I want to thank our guests for being here.
And I think one takeaway thing, it's going to have to come from the community, because I beat my head on every other wall, and really it's going to have to be the families. Unfortunately, the families have often been very disempowered because they run up against people at these facilities who say your patient isn't sick enough, or they don't listen to them when they say they're afraid somebody's going to hurt them. And so the families really need to be empowered. If you know people who are families, please support them. And it's going to have to come from them coming back again and getting like NAMI involved, so that there is a way to address that these people do require a lot more care that they're giving. The care that they're getting now is way less than they got 10 years ago, and the bar is that much higher for anybody to get help.
Thank you. Thank you.
So thank you everybody for coming. There is some snacks and water in the back if you guys want any of those on your way out, or run us some people here for a while. Thanks for coming. Hope to see you next month.